Hello, today I'm going to talk to you about ARDS, Acute Respiratory Distress Syndrome. Definition: ARDS is a type of respiratory failure characterized by diffuse damage to the alveolar capillary membranes from fluid buildup causing hypoxemia. Breathing becomes increasingly difficult, and surfactant breaks down, which prevents the alveolar sacs from filling up with air. The final Berlin definition of ARDS classifies patients as having PaO2-FiO2 ratios of 201 to 300 millimeters mercury as mild, moderate for PaO2-FiO2 ratios of 101 to 200 millimeters mercury, and severe for PaO2-FiO2 ratios of less than 100 millimeters mercury. Etiology: There are multiple conditions that are associated with ARDS. Factors fall under either direct lung injury, called primary ARDS, and those caused by indirect lung injury are called secondary ARDS. Secondary ARDS is caused by inflammation, which promotes pro-inflammatory mediators leading to the release of neutrophils to the alveoli. Patients with sepsis are considered to have the be highest at risk of developing ARDS. So the primary ARDS common causes include pneumonia and aspiration of gastric contents. Some uncommon causes include pulmonary contusion, near drowning experiences, and inhalation injuries. Secondary ARDS common causes include sepsis and blood transfusion. Uncommon causes are drug overdose and cardiopulmonary bypass. Risk factors for ARDS includes infections like COVID-19 virus, pneumonia, and sepsis. The environment plays a role, so going to any geographical locations that have low air quality or high levels of pollution. Lifestyle habits, so alcohol consumption, overdose of drugs, or smoking and vaping. Um, Also, any other underlying medical conditions, like inhaling water, injury from blow or burn, lung surgery, presence of chronic lung disease, old age, and pancreatitis. Some ways to help prevent ARDS starts with completing routine vaccines checkups to prevent infections, not smoking or vaping, limiting the alcohol consumption, and also reducing exposure to low air quality. Diagnosis of ARDS. There is no single test that can definitely diagnose for ARDS alone. However, physicians will consider underlying issues and check patient history in conjunction with physical examination. They will look for signs that show shortness of breath, faster than normal respiratory rates, higher heart rates, distress when taking in a breath, listening for crackling sounds in the lungs, checking in the heart, examining skin and body for swelling and signs of low oxygenation, blood pressure, using a pulse oximetry, chest x-rays, and CT scans for detailed images of the lungs, lung biopsy. Also checking past medical history and events that may be considered a risk, like traveling to areas that may contain low air quality. Checking for acute onset of bilateral chest infiltrates on chest radiograph, and assessing PaO2 FiO2 ratios of less than 300 millimeters mercury. Also, determining left ventricular function to identify if congestive heart failure contributes to the clinical presentations of the patient is done by using a cardiac echocardiography. Finally, extra tests like sputum culture collection Bronchoscopy and urine tests are also conducted to determine cause of infections and diagnosis when there is no clear cause. Anatomic alterations associated with ARDS include possibly atelectasis, decreased surfactant around the alveolar walls, intraalveolar hyaline membrane formed, alveolar consolidation, and interstitial and intraalveolar edema. When you get an injury to the lungs, the pulmonary capillaries swell up, and the permeability of the capillary membranes increase. Interstitial and intraalveolar edema occurs, and the areas of alveolar consolidation causes a decrease in surfactant, which leads to possible atelectasis. As the disease progresses, intraalveolar walls start to cover with hyaline membrane containing fibrin. Fibrin and exudates lead to fibrosis and swelling of type 2 alveolar cells. Pathophysiology. In ARDS, the injured lung is believed to go through three phases: exudative, proliferative, and fibrotic. In the exudative phase, damage to the type 1 alveolar epithelium and separation of the basement membrane leads to the impairment of the normal anatomic barrier, which causes leakage of protein-rich fluid into the alveolar space. These changes are induced by a complex interplay of pro-inflammatory and anti-inflammatory mediators. Type 1 alveolar cells are irreversibly damaged, and the basement membrane is now replaced with fibrin and cellular debris, producing a hyaline membrane. Meanwhile, injury to the surfactant-producing type 2 cells contributes to alveolar collapse. In the proliferative phase, type 2 cells proliferate with increased accumulation of fibrotic material. The fibrotic phase involves collagen deposition in alveoli and the destruction of pulmonary vasculature from fibrosis. Direct and indirect injury to the lungs causes rapid reproduction of inflammatory mediators, activating the accumulation of neutrophils in the alveolar space. Neutrophils migrate in large groups and release protease, cytokines, and oxidants. This causes the vascular permeability to increase, gaps in the epithelium layer to form, and necrosis of type 1 and type 2 alveolar cells. The hyaline membrane formation and the loss of surfactant leads to increased difficulty of breathing. Clinical presentation of ARDS. Patients with ARDS are symptomatic for progressive dyspnea. In the first few days, patients show decrease in lung compliance from low levels of surfactant. Hypoxemia and lower lung compliance together leads to rapid shallow breathing and an increased work of breathing. A chest radiograph findings of patients with ARDS shows ranges from mild bilateral infiltrates to dense consolidation, which represents the non-cardiogenic pulmonary edema. ARDS that progresses longer than 7 days enters the fibroproliferative state, where hypoxemia may subside, but lung compliance is still low from fibrosis. Here on the right is two images of a chest x-ray, as you can see, image A and B. Image A is a chest x-ray of a patient with ARDS that shows bilateral infiltrates. There is bilateral consolidation and a right pulmonary effusion. I would like to also point out that the costophrenic angles have turned blunt on the right lung on picture A and B, and you can see the white around the consolidation around the lungs. Management of ARDS. Early detection and treatment of underlying pathophysiology is crucial. Management mainly focuses on increasing oxygen delivery and avoiding further damage from mechanical ventilation. They also look at the appropriate use of antibiotics, surgical intervention, mechanical ventilation and supportive care, and nutritional support. Muscle wasting is common among patients with ARDS, and they have a difficult time eating, so patients are given parenteral or enteral feeding based on the conditions of their gastrointestinal tract. Neuromuscular blockers are also used to help increase lung compliance and achieve oxygenation target during early stages of ARDS. Finally, care is also placed on preventing volutrauma, which is exposure to high tidal volume, and barotrauma, exposure to high plateau pressure, using lung protective ventilatory strategies by setting parameters to having tidal volume about 6 milliliters per kilogram of ideal body weight, having a respiratory rate up to 35 beats per minute, having SpO2 of 88 to 95%, having a plateau pressure less than 30 centimeters H2O, having an inspiratory and expiratory time of less than 1 second, and having a pH goal of 7.35 to a 7.45 range. Treatment for ARDS. Oxygen therapy to increase blood oxygen levels and ventilating to keep airways open. Prone positioning. ARDS patients usually lay on their back in bed. When blood oxygen levels are low, even after ventilating, patients may be placed in prone positioning, which is laying on their stomach to promote use of parts of the lungs that aren't used to increase oxygen in blood. Sedation to prevent movement and reduce discomfort from shortness of breath. Fluid management. Restore fluid levels by using diuretics to increase urination and removal of excessive fluid within the body. And finally, extracorporeal membrane oxygenation, which moves blood outside of the body, removes CO2 through a membrane, and adds oxygen, then returns the blood back into the body. Prognosis. Advanced research has created better patient care for individuals with ARDS. 25 to 40% of patients with ARDS did not survive up until the 1990s. Now, mortality rates average around 9 to 20% with the use of modern advancements in mechanical ventilatory support. Older people still have significantly higher rates of mortality. Weight loss, impaired functions, and weak respiratory muscles requiring pulmonary rehabilitation are the likely course of the disease. And near complete recovery of pulmonary capabilities is still possible, but they still experience dyspnea and reduced exercise tolerance. Finally, the role of RT in the management of ARDS includes operating the ventilator and setting appropriate parameters for respiratory support, assisting in bronchoscopy, providing oxygen therapy, and educating the patients on the meaning of ARDS, signs and risk factors, the management and treatment of the disease.